Good evening and welcome. I'm Jennifer Leopard, president of the Michigan chapter of the Alzheimer's Association, and I've had the great pleasure in working with the people that you're going to hear tonight putting this event together. We're so happy to have you join us this evening. Just a couple of things before we get started. We're going to be using the Q&A feature tonight to ask questions, so please put any questions you have as our speakers are speaking into Q&A. We'll be doing one question period at the end after all our speakers have given their presentations, and we will be following up with those of you who have questions that we can't get to, which we certainly anticipate there will be some questions that we're unable to get to tonight. Already somebody's asked about a recording. We will have the recording available, and we will also have the slides available to people afterwards. So we will make sure that that gets out to you. So I really want to briefly introduce our panelists for this evening. Very excited to have such a great group here this evening. We're going to be hearing from Dr. Rebecca Edelmayer. She is the Senior Director of Scientific Engagement at the Alzheimer's Association. We are then very pleased to have representatives from West Virginia, Ohio, and Michigan all speaking to us this evening. We'll hear from Dr. Mark Haupt with the Rockefeller Neuroscience Institute at West Virginia University. We'll then hear from Dr. Bruno Giordani from the University of Michigan and the Michigan Alzheimer's Disease Center. And then we will close with Dr. Jagan Pillai of the Lou Ruvo Center for Brain Health at the Cleveland Clinic and Case Western Reserve University. So without further ado, I know you are all here to hear from our speakers. I'm going to turn it over to Rebecca, and thank you again for coming.
Thank you so much, Jennifer. And it's such a pleasure to be here with all of you this evening. I'm so happy to see so many joining to learn more about the latest in Alzheimer's and dementia research and future of treatment. On our next slide, I think what I'll show you is what I hope to cover today, which really is a landscape of Alzheimer's and dementia science. I'm going to highlight a few areas of early detection and diagnosis that are currently in development today. We're also going to talk about some of the latest advances in clinical trials, treatments, and lifestyle interventions. And then last but not least, I want to make sure that you can keep your fingers on the tabs of everything that's happening in research. So I'm going to show you a few ways that you can do that or even participate in clinical trials. So on the next slide, you just saw, I think, as you were entering the webinar tonight, a video of some of the facts and figures associated with Alzheimer's disease and other dementia. And here are a few of those figures again for you to view. But as you know, all very clearly, Alzheimer's disease and other dementia have a huge impact on individuals, families, and our entire society. And research really is the way that will push us forward into the next generations of a place where we will hopefully be living without Alzheimer's disease and other dementias in a way that they're affecting our communities as they are today. So I hope today you will see the progress and you will see the advances that are being made each day to get us and move us in that direction. On the next slide, I just want to make sure we set sort of a groundwork for everyone who's attending today. I think one of the biggest questions that I get asked when doing educational seminars is, what is the difference between Alzheimer's and dementia? And this slide, I think, gives you a little bit of an example of what we're trying to say when we talk about these two different terminologies. Really, when we say dementia, it's an umbrella term that's used to describe a range or collection of symptoms that are associated with cognitive impairment. Alzheimer's disease happens to be the most common cause of a most common neurodegenerative disease that causes symptoms of dementia. But as you can see, vascular disease, Lewy body disease, frontotemporal disease, all of these are associated with hallmark changes in the brain of individuals that are living with them, but that are also driving the behavioral and cognitive changes associated with these diseases. One thing to note is that mixed dementia is very common. Probably about 50% of people, maybe even more than 50% of people, are living with what we would call neuropathology, or the sort of pathological brain changes that are going to be associated with maybe not only Alzheimer's, but also vascular disease as well, or Alzheimer's, and even some of the pathology associated with Lewy body dementia. So that makes it difficult to study these diseases. It makes it difficult to also develop treatments. But as we move forward, we will hopefully in the future continue to design better tools and technologies to diagnose, the individual, but also to be able to develop treatments that are going to be most effective. Now let's dive a little bit into the hallmarks of Alzheimer's disease. On the next slide, you'll see some of the key hallmarks that we'll be talking about throughout the presentation and probably some of the other speakers' presentations today. And I want to make sure we point out a few of those hallmarks. And these are not necessarily causes of Alzheimer's disease, but we know they're present in the brain of individuals that are living with Alzheimer's. And amyloid beta is one of those proteins that's in the brain. It builds up into plaques around the cells. Also, the tau tangles, it's another protein that sort of tangles up sort of the communication pipelines inside the cells. And both of these are thought to contribute to sort of the neuronal cell death and even the shrinkage of the brain tissue in the areas that are most associated with our memory, our thinking, our learning, and even some of our behaviors. And you can see that. I know I'm having a little bit of instability here on my camera, so I just want to make sure you can hear me okay. An image of what is really telling us more about the disease continuum. And the disease continuum is really want people to understand Alzheimer's disease is not, it's not something that happens overnight. It's a process that occurs. And so individuals may be living with some of those hallmark changes in their brain that are sort of the amyloid, the tau, even some of that neurodegeneration, but they may not be experiencing any symptom, any cognitive or behavioral symptoms of the disease. But then there's another phase called mild cognitive impairment due to Alzheimer's disease. And that means the individuals may be experiencing some cognitive changes that are not typically affecting most of their activities of daily living, but they do have those hallmark signs of Alzheimer's in their brain. And then you move into this sort of dementia stage of Alzheimer's disease, where an individual may be living with mild, moderate, or severe dementia. Now, this moves across the continuum over time, and it typically involves symptoms that interfere with someone's activities of daily living, and they become more pronounced as people move through sort of the disease stages. And you get to a point where the symptoms will interfere with most activities of daily living once you get to the severe stages. Now, that's really important because as we continue to do research, we're starting to identify different stages of disease where different treatments may be most effective. And I think on our next slide too, we're going to start talking about what puts someone at risk for developing cognitive decline or dementia. Now, there are so many things that may contribute to an individual's risk or even a group's risk. We now are understanding more and more about this, but this is a constantly evolving situation when we start talking about risk. We know that age is the biggest risk factor for Alzheimer's disease. Genetics also play a role, and race or even the biological sex can play a role. These are things that are non-modifiable risk factors. However, we also know that there are modifiable risk factors, things like diet, things like physical activity, things that contribute to our cardiovascular health, traumatic brain injury, education, even environmental or social lifestyle factors. These could potentially contribute to our overall risk. Now, there's a constellation of reasons that may be both fundamental but also unique to each individual. And as research progresses, we need to kind of continue to include all individuals in our research so we better understand what's driving risk for these groups of individuals. I think one thing to really point out here is that social determinants of health may really impact some or all of these factors. And there's a lot of research ongoing to try to understand how environmental, behavioral, and social contributors will change an individual's risk and some of the components of these risks that you see here. But there really is a critical need to continue to understand risk from all angles. And that brings me to my next slide, because the reason we have to absolutely understand it from all angles is that we know today that gender, racial, and ethnic disparities exist in Alzheimer's prevalence. And they also exist in who is participating in clinical trials. We know today that almost 2/3 of Americans with Alzheimer's are women, We also know that older Black and Hispanic Americans are more disproportionately affected than older whites to have Alzheimer's or other dementias. We also know that ethno-racial groups have been historically underrepresented in clinical studies, which really underscores the need for more diversity in dementia research. And now I want to start talking about how we're trying to make sure that individuals are being incorporated and we're creating inclusive trial situations and studies moving forward. On the next slide, we've been learning about how combining healthy lifestyles may be a place where can potentially drive down risk for individuals, but we need to be able to study what those lifestyle factors are in intervention style studies. Now, we see a lot of work in epidemiology as well as observational research that would suggest that combining some of these healthy lifestyle factors may drive down our risk for developing Alzheimer's or another dementia. You can see healthy diet here, moderate to vigorous physical activity, little to no smoking, alcohol intake, and even cognitive stimulation. We saw back at our Alzheimer's Association International Conference in 2019 that combining these factors really may offset some risk, and it potentially may even offset risk associated with our genetics. But more research really needs to be done to truly understand which of these factors or which combination of factors are going to be most beneficial. One way we're doing this through the Alzheimer's Association, on the next slide, you'll see is that we are leading the landmark study called the US Pointer Study. This is the US study to protect brain health through lifestyle intervention to reduce risk. This is a 2-year clinical trial that's inviting over 2,000 participants from 5 different clinical sites across our communities. They'll be going through a self-guided versus a structured lifestyle intervention that includes physical activity, nutrition, intellectual engagement, as well as health coaching. The goal of this study is to truly learn through a multi-domain intervention if this is able to drive down the development of risk, drive down the risk for developing cognitive impairment in individuals who have a family history or even a sort of maybe living a suboptimal lifestyle in terms of their diet, exercise, physical activity, and cognitive and social engagement to see if that's really something that is beneficial. If the intervention proves effective, then this study really will hopefully lead to a sustainable way to develop community-based programs for prevention. But we're not there yet. We still need to do more. On the next slide, it sort of outlines sort of those 2 different interventions that are being used in the US Pointer Study. All of the individuals get the same information, but it differs in format, expectations, and accountability. So when we think about driving down risk, we also have to think about how do we implement strategies like this out in our community. We all know that we should be taking better care of our health and doing more exercise and eating better. But in a way, we need to truly understand if this is going to change our risk for developing cognitive impairment in our brains and what that recipe for risk reduction really is. On our next slide, I want to switch to talking a little bit more about biomarkers and what that really means for our field. We need to be able to detect disease and diagnose individuals at earliest stages, and biomarkers are one of the ways that we will do this. Now, you probably all are familiar with biomarkers. You may not think you are, but you definitely are. We know them maybe through other types of tests that you get at your doctor's office. We know them to be really a way of being a reliable predictor or indicator of disease or disease progression. You could think of something like glucose to measure insulin resistance and even look at your risk for developing diabetes. That's a biomarker. You could think of cholesterol as looking at your risk for developing heart disease. But we need these types of tools and technologies as well in Alzheimer's and other dementias. And they can help enroll people in clinical trials. They call that clinical trial enrichment. They could be used as prognostic indicators to determine the course of an illness. They can also be used as predictive indicators of whether or not a treatment is going to be safe or even effective. And on our next slide is just a fantastic image to me that describes really where we are today in the field. Biomarkers are changing the game. We used to only rely on being able to look at an individual's brain tissue under a microscope after they passed away to actually diagnose if they had Alzheimer's disease. But today, researchers have created and are continuing to create more and more tools to help aid in the diagnostic process so that we're not only relying on cognitive testing and functional testing. We are looking at brain imaging, biofluid analysis, looking at cerebrospinal fluid and blood samples. We're also seeing even advances in retinal imaging using the eye as a window into the brain, or even our DNA and our genetics. How does that actually fit into an algorithm for risk? And when we look at how, on the next slide, of how we've really been trying to modernize the diagnosis, we used to only diagnose individuals, as I mentioned, through a sort of medical history and cognitive exams. But we've learned now that a lot of those biomarker changes are occurring probably 10 to 20 years before anyone is even showing any signs or symptoms of Alzheimer's disease or any other dementia. So that really gives us a window to start trying to identify people at earlier stages of disease to hopefully identify the best treatment pathways and the best care pathways moving forward. On the next slide, I want to talk a little bit about the progress that we're making towards a blood test. We have seen remarkable progress in this space. There's been a global race to really uncover and develop blood-based biomarkers for Alzheimer's and other dementias. We've seen more research recently validating amyloid beta in the blood and even tau biomarkers in the blood by comparing them back to imaging results like PET imaging or MRI imaging, and also cognitive testing results. And at our Alzheimer's Association International Conference in 2021, it was really the first time that we saw some rigorous, what we would call plasma or blood p-tau data that was presented in the context of a clinical study. And in this phase 2 clinical trial, they were using an anti-amyloid drug, so to remove the amyloid from the brain. But removing the amyloid also resulted in reduced levels of amyloid in the brain by looking at the blood. We actually saw they reduced the levels of tau in the blood as well by looking at p-tau 217, a very specific form of tau protein that's indicative of changes of tau buildup in the brain. And it was associated with decline in cognition and function. So this is a way that we're using a biomarker to really look at the effectiveness of a treatment in the brain. Now, I want to bring up another type of biomarker on the next slide, and this is looking at amyloid PET imaging. Amyloid PET imaging is really that was done with a tracer that looks at sticking to that amyloid in the brain. Now, this is an approved technology by the FDA. We're certainly still looking for people to have more access to this type of biomarker because currently people do not have access. It's not covered by insurance. But this study called the IDEA study, it stands for Imaging Dementia Evidence for Amyloid Scanning, being led by the Alzheimer's Association in collaboration with the Centers for Medicare and Medicaid. And it brought in over 18,000 individuals to look at the utility of amyloid PET imaging to see if it had an impact on care management. So if you could give people an amyloid PET image, does it actually change the way the doctor prescribes, diagnoses, or even does it change the impact on major medical outcomes like ER visits or things like falls or hospitalizations? Knowing this information about your amyloid status is something that may be very beneficial because if you do not know what's causing your cognitive impairment, it may be due to Alzheimer's, but it could also be due to something else like side effects from medications or metabolic toxicity. And a doctor needs to have tools at their fingertips to be able to get to the bottom of what may be inducing that cognitive impairment. What we've learned from this study so far is that individuals who received amyloid PET imaging and had a positive amyloid scan, about 2/3 of the participants had a change in their diagnosis and a change in their care management as a result of these PET scans. So that's really critical. I think on the next slide, though, it exemplifies things that we need to still do better and learn more from the IDEA study. We now have a new iteration of this study that's ongoing called New Ideas. And this is really a way for us to continue improving precision amyloid PET coverage and patient care. This study is going to be enrolling over 7,000 individuals to really assess PET imaging results to see how they guide doctors and diagnose and treat memory conditions in participants of diverse racial and ethnic backgrounds. In this particular study, we are enrolling over 2,000 individuals who self-identify as Black or African American, and 2,000 that self-identify as Hispanic or Latino. And it's really critical because even though the original IDEA study enrolled 18,000 individuals, the population of that study was still not necessarily representative of the Medicare population in terms of race and ethnicity. And so we're working with CMS again to truly understand what these biomarkers tell us and how they inform care practices moving forward. So really critical work that's happening. So on our next slide, I think I want to try to encapsulate and sort of end the biomarker part of the talk and just sort of to try to give you a framework of what we're trying to do here. We're trying to continue to understand what the different brain changes are. We're trying to develop the biomarker strategies to be able to look at those different brain changes, whether it be brain imaging, cerebral spinal fluid analysis, or even blood. And then we're trying to use that information to help us better define what therapies we should develop, but also who may be a right fit for those therapeutics. On the next slide, I do want to start digging into where we are with treatments. We now have, I think, 6, if I'm looking at this correctly, FDA-approved treatments that are aimed at sort of the cognitive symptoms of Alzheimer's disease. If you look at the first 5 medications that are there, these are really available to therapies that are meant to sort of treat the symptoms of cognition. They don't really change the disease progression. But in 2021, I think you'll hear a little bit more about this from Dr. Ply, but in 2021, we had the first approved treatment that really is aimed at addressing some of the underlying biology of Alzheimer's disease. And that's a drug called aducanumab or Aduhelm, and it's targeting the amyloid in the brain. And so let's talk a little bit more about the way this drug works, because it's very different than some of those other drugs that you see on the screen there. On the next slide, we'll see what beta amyloid really is. And I know this is kind of a confusing slide, and it's really hard to sort of draw this out as a scientist, but you look at the image on the left of your screen, that's the plaque, that's the amyloid beta plaque, and it's a protein sort of ball of proteins that you see. But what's really happening is plaques are formed by a lot of different sort of protein structures, and they're called oligomers and monomers and fibrils and protofibrils, and they all kind of change and develop over time in this sort of dynamic process. Well, on the next slide, what we're trying to do with some of these drugs is we're trying to actually develop what we call monoclonal antibodies, and they target sort of the amyloid species that build up in plaques. And many of these drugs do it by slightly different ways, but this is sort of an overall picture. The drugs are able to go into the brain, stick to the amyloid, and help with its either removal or breakdown so that the body is capable of excreting it over time, and it doesn't build up in your brain. On the next slide, I'll give you just another example of that original image. We have multiple drugs that are currently in the clinical trial pipeline today that are targeting amyloid. We call these a class of monoclonal antibody targeting agents. You can see aducanumab there in blue, donanemab, lecanemab, gantenerumab, and solanezumab. All of them target amyloid slightly differently. And on this, it sort of, again, gives you an example of what we mean by a class of therapeutics. What we mean by a class of therapeutics is that it's a set of medications or other compounds that sort of have similar chemical structures. They may have similar or related mechanisms or mode of action. They may also be used to treat the same disease. But on the next slide, what I want you to see is that there are over 100 unique therapies being tested in clinical trials today, not just anti-amyloid therapeutics. They're just the furthest along in the clinical trial pipeline. But many of these therapeutics are targeting multiple aspects of Alzheimer's biology. You can see amyloid beta on this graphic, tau, vascular stress, bioenergetics, cellular communication, even neuroinflammation. All of these are being targeted today. And on the next slide, I think it even shows you more about how many different clinical trials there are. The landscape of clinical trials for Alzheimer's and other dementias is quite great. This is just showing you the drugs and devices that are being tested today. And you can see through phase 1 clinical trials, phase 2 and phase 3 clinical trials, as they increase in number in terms of their phases, they also increase in their complexity and sometimes the length of the study that's needed. But we need all individuals to participate in these studies so that we can make progress on developing new treatments. On the next slide, I want to show you where we are today in terms of how we're going to continue to follow new individuals who, new drugs that are approved by the FDA with greater care. The Alzheimer's Association announced in November at the Clinical Trials in Alzheimer's Disease conference that we would be launching an Alzheimer's National Registry for treatment and diagnostics. We're currently calling it ALZNet. And you can see here on the slide, Drs. Maria Carrillo, who's the Chief Science Officer of the Alzheimer's Association, Dr. Gil Rabinovich from the University of California, San Francisco, and Dr. Michael Rafi from the University of Southern California are all the co-principal investigators of this registry. And you can see some of our study team partners here who we've worked very closely with for the New Ideas and the Ideas study, develop those massive research studies across the United States, the American College of Radiology, the Brown University School of Public Health, the American Society of Neuroradiology, as well as the Critical Path Institute. On the next slide, it shows you what we're trying to do with this registry. It's really aimed at developing a multi-site network that's going to enroll individuals into this study that will allow for data collection from those individuals who are taking any newly approved Alzheimer's disease treatment. We'll be able to collect patient data at the start and over time, including measures of cognition and function and safety. We'll also be able to track health outcomes and resource utilization of the participants. We'll be able to collect information about brain scans, as well as genetic and biomarker and blood sample information. And the goal of this really is to help the field move forward and researchers and clinicians to understand what treatments are doing and are they changing disease progression and are they being able to be prescribed in a safe manner. We'll also be able to do that through sharing de-identified data, brain scans, and blood samples with the research community. On the next slide, I hope you can really see how the association is continuing to try to engage physicians through not only the ideas, the new ideas, and the ALZNet registry in creating a national network of research studies that are going to be aiding and moving all of what we're learning in research out into clinical care. And it's integrating that clinical care and cutting edge research together with treatment, and ultimately is going to be improving health outcomes for everyone. So overall, I think on the next slide, in terms of the summary of what I hope you walk away from this talk today, is that we really are in a new era of treatment. This is evidence-based science that's now moving into care and moving into your clinician's office. It is all research-based. And what we will continue to do moving forward is, as the research evolves, treatments will evolve, and they will be refined over time until we get to the point where these treatments will be transformational, as I mentioned earliest in the talk, for both individuals and their families. And if you're interested in getting involved in research, on our next slide, I hope you will look at the opportunities that exist in Trial Match. This is a free clinical matching portal for clinical studies matching portal that the Alzheimer's Association offers. You can find it very easily at alz.org/trialmatch. There's over 700 clinical studies at locations around the US and also around the world. And this will help to provide you or your loved one, a friend or family member, a list of studies that may be a right fit for you. And they're looking for all individuals to get involved. You could be what we would call a healthy volunteer. You could be a caregiver. You could be living with cognitive impairment. You could not be living with cognitive impairment. And there's so many different studies to look at. You could be testing a new drug. You could be testing a new blood test. You could be doing an exercise study. So please consider this as an opportunity to get involved in research, because one of the biggest hurdles that we have in making progress is making sure that individuals get enrolled and engaged and retained in clinical studies. And I know you're going to hear more about those clinical studies after I finish my talk here. And last but not least, I think I want to just direct you to our Science Hub app on our last slide. If you want to keep a finger on the pulse of all things happening in research, the Alzheimer's Association does offer you a mechanism to do this. I have this on my phone myself, and my colleagues and I at the association help provide a lot of expert viewpoints and distill a lot of the research information that you may be seeing in the news every day down to something that's digestible and some key takeaways for you, so you can really understand what progress we're making. You can download this app anywhere you get your apps. So you can also find more information about this, I think, at alz.org/trialmatch or /. I hope you enjoyed the talk, and happy to take any questions at the end of our session. I'm now going to turn it over to Dr. Mark Hout. Thank you, Mark.
Thank you very much, Rebecca. I appreciate that talk. It was an excellent introduction to what we're going to talk about. To tell you a little bit about myself, I'm Mark Hout. I'm a neuropsychologist by training here at West Virginia University. I've actually spent my entire career here at West Virginia University, over 30 years now. And throughout that time, I've worked with patients and families who suffer from Alzheimer's disease or other dementias, and also done research within this area. Next slide, please. So after being here for 30 years, you might think that I might be ready for retirement, but I absolutely am not, because within the last few years working within the Rockefeller Neuroscience Institute, I've had an opportunity to get involved in some research that is, you might call it advanced, technological, cutting edge, but really exciting and making some progress that I hope will apply not only to Alzheimer's, but to a variety of other neurodegenerative conditions. As part of my role here at the Rockefeller Neuroscience Institute, I'm involved in conducting clinical trials. And I wanted to talk with you a little bit about clinical trials and what it's like to either conduct them or participate in them, to give you just a little bit of a sense of how we approach this and how we would like potential participants to think about this. When I think about clinical trials and why somebody would participate in a clinical trial, I see two big buckets that kind of come together. One is that most patients and families have some hope that if they participate in a clinical trial, it may lead to a better outcome for them. Maybe they will be the person who responds to the treatment, or maybe this will be the treatment that works and helps them. And I think it's great to have that hope. Without dousing the flames completely, I make sure people understand that if it were clear that this worked, it wouldn't be research and we wouldn't be doing a clinical trial. But I want you to have that hope to participate. But that it's really important to be in this for other reasons. And that's to help not only yourself, but maybe your family and other people throughout the world to understand this disease better so that we can develop those treatments. And it's only through participation that that can happen. But I'll tell you, it's not for everybody, and that's okay. When I talk to people about participating in research, if they're my clinical patient or they're just calling up, I let them know that we'll help them in any way that we can. But if they're not interested in doing research, that's fine. And that's actually good to know, because you don't want somebody to be involved in research and doing the research and participating in a trial if they're not really invested, because that means you don't get as good data. And it's really important that you have good data so you have good outcomes for this. One of the things that I think about in terms of how this can lead to advancements is with pediatric cancer, actually. To give you just a touch of background, more background about me, my father, by the way, who is 95, sharp as a tack, he sends me longer texts than I can ever type, is a retired oncologist. And my younger brother, his other son, is a pediatric oncologist. And I know from both of them have worked throughout their career in academic medical centers, that they try to enroll every one of their patients in clinical trials. And actually early on for pediatric cancer, there were very few patients in the United States who were treated for pediatric cancer who weren't involved in some kind of clinical trial. And the results of that were, for example, changes in death rates for leukemia for young kids just changed dramatically because the effort was there, the involvement was there, and everybody was participating, and the outcome just really improved. We are nowhere near that with adult patients for oncology, much less for Alzheimer's disease. And it kind of puts us behind in that. But I will emphasize again that you have to be in to do this. And if you're not, that's okay. You have to do what's best for you. And if you do what's best for you, it will be best for us also in trying to understand the disease. Next slide, please. When I do clinical work and when I do research, I try to follow what I call the mother rule. So I grew up in the South. My parents are from the East Coast, but my mom, she fit into the South really pretty well. She was a good Southern mom, is what I would say. I was very, very close to her. And she developed Alzheimer's disease, actually. And I could see it developing in her when she was in her early 70s. It was very difficult for me to see that with my mom, who I was so close to. And I started reflecting on that. And as I looked for people to find and take care of her, I decided that I was only going to choose people that I was really, really comfortable with. And then I end up saying to myself, well, why am I just doing that for my mother? Why shouldn't I try to do that for everybody? That you want everybody to get the same care that you would want for your mother in terms of providing it as a clinician. And then as I started doing more research, I really started thinking about, if I'm doing research to really help with this, because it does run in my family, as you can see, my mother, her mother, my grandmother, and then her brother, my Uncle Ted. They all died from Alzheimer's disease. If I'm going to do research in this, I have to make sure it really counts, but I have to make sure that it's really safe. And I only want to do research that my mother would want to participate in if she qualified and thought it was safe. So I have to be really comfortable with it. And if I'm comfortable with what we're doing, I think the patients and the research participants will understand that, and they'll get some sense of comfort from that also. So I try to follow the mother rule all the time. I don't always succeed, but I try to follow that with everything that I do with patients in clinic as well as in research. Next slide, please. So some of the trials that we do here at the R&I, as we call it, by the way, the R&I is named for the Rockefeller family. Senator J. Rockefeller's mother, Blanchette, actually died from Alzheimer's disease. And that's why we have the Rockefeller Neuroscience Institute here at West Virginia University with a primary focus on Alzheimer's. We conduct what I'll call small, intimate trials, and we're going to talk about one of them shortly. These trials are really focused on a small number of subjects. The trial that we're going to discuss, we've only run 9 subjects in it in 2.5 years. I can tell you we screened a whole lot, but it's very, very intense. It's very, very involved. It's not for everybody, but we have to make everything actually count. We can't lose anything from these trials. We have to learn everything. The data has to be pristine and good so that we learn, or the patients have participated in this for nothing. So we take it very, very seriously. We take care of our patients really, really well, and they're very, very intense and very, very small to make everything count. And the thing that I've learned over time is that you'll get that really good data if you're treating patients and participants and families really well. If you treat them well, the data would be better, everything will be smooth. And so it's a little hard to do if you're running a huge trial with hundreds and hundreds of patients. But in these small trials, we've been fairly successful at doing this. And I'm hopeful that it'll lead to better outcomes. Next slide, please. So let's talk about this trial that we're doing here at the R&I. It's using focused ultrasound. Now, I just picked a few pictures of some of the team members here so that you could see who they are. But you can see there's a huge number of people who are involved in this study. Again, for 9 subjects to date that we've completed. Dr. Razai, who's a neurosurgeon, heads up the trial. We have Dr. Najib, one of our neurologists. I remember him well when he was a resident. And Padma, one of my favorite people in the world, who runs all the regulatory and research people. Dr. Carpenter, who is a wicked smart neuroradiologist and engineer, helps us run the device. And Dr. Mehta is amazing as a neuroradiologist in helping us pick targets. But everybody has a role in this, and everybody plays a part, and it's truly a team effort, and I'm proud to be part of that. Next slide, please. So what are we trying to address with this focused ultrasound trial? The primary problem is because of what's called the blood-brain barrier, and you'll get a little bit of an introduction to that in just a minute. Things are prevented from getting into the brain. It also keeps things in the brain because of this barrier. And one of the problems is if you're giving a treatment systemically through an IV, for example, how does enough of that drug or whatever the agent is penetrate into the brain to take care of the brain problem without getting you toxic in the rest of your body and symptoms? When I was an intern back in the early mid 80s, people were trying to deal with this blood-brain barrier to get chemotherapy agents in there, and they've still been trying to do that until recently. Focused ultrasound is one way to be able to do that, to get around this barrier so that you may be able to get drugs in specifically to target areas of the brain. Next slide, please. Right now, I'm hopeful.
Inside the brain.
Here we go. Watch the video.
Inside the brain is a shield that protects against invaders. It's called the blood-brain barrier. It allows nutrients to reach brain cells from the bloodstream while filtering out germs and other harmful substances. But there's a downside. Drugs needed to treat brain diseases too often can't get through either. The blood-brain barrier is made up of cells that line most of the brain's smallest blood vessels. Those endothelial cells are tightly packed together, so only small molecules slip by. Many drugs for cancer, Alzheimer's, and other brain diseases are too big to easily pass through. But what if scientists could make the blood-brain barrier temporarily leak in just the right spot in hopes of one day helping those medicines sneak inside? To try, they inject microscopic bubbles into the bloodstream. MRI scans pinpoint the desired brain location. Then, researchers beam what's called focused ultrasound right at that spot. The ultrasound waves make the microbubbles vibrate, creating a temporary opening in the blood-brain barrier. An experiment with a handful of Alzheimer's patients shows the barrier opened, let some harmless dye seep in, and then sealed back up. Similar small safety tests are getting underway with brain tumor patients and people with Lou Gehrig's disease.
Thank you. Next slide, please. So the problem is, how do we get rid of the amyloid plaques and the tau tangles? Can we get things into the brain through the blood-brain barrier to be able to do this? And the goal of our study is really very early in the process. It's a safety study to make sure that we can do this safely and not harm patients. And then later on, we'll see if we can introduce a treatment. Next slide, please. One of the things I want you to keep in mind was introduced by Rebecca also. Time is brain. And so the earlier you can identify somebody with confidence that they're likely to have this disease, the better it is to intervene before the symptoms develop. When we see an MRI scan like this in clinic with that much atrophy in the short-term memory part, the hippocampus, or that much decreased metabolism or energy use in the temporal lobes, it's too late for most of these treatments that we're trying to get through. We have to figure this out earlier, and we have to be able to get these drugs in quicker. One of my concerns about some of the monoclonal antibodies is that it can take 6 to 12 months to get the levels into the brain to remove the amyloid. 6 to 12 months is a lot of time to be losing brain skills that we may not get back. And so we worry about that also. Next slide, please. So Dr. Lipsman at Toronto was the first to do this with Alzheimer's patients and published the data back in 2018. And we had the good fortune to go up there and train with his team and learn about doing this procedure before we brought it back here to West Virginia. Next slide, please. What we've been able to do in the first series of patients is specifically target the hippocampus, the short-term memory part of the brain. Direct the focused ultrasound to that area, have it open up the blood-brain barrier, and then have it close within 24 to 48 hours later. If you look at these slides, you'll see on the top, the baseline, there's no arrows. In the middle, you see arrows pointing at some white spots. Those white spots are contrast enhancement that leaks through the blood-brain barrier when it's open. And then 24 hours later, it's gone, meaning the barrier closed back up. So we were able to open the barrier in 6 patients, just in the hippocampus, have it close back up quickly with no ill effects, which is good. But some of the scientists may say, well, why do you want to do that in the hippocampus? Because there's really no amyloid in the hippocampus. And we're able to show that there was a decrease in amyloid, but we just showed the barrier could be opened, it could close without harmful effects. The next phase, which we're working on now, next slide, please, is really trying to figure out how can we get it where it needs to go. If you look at these scans, the arrows point to buildup of amyloid in the brain in very specific regions. You see large amounts of it in the frontal lobe and in the parietal cortex and the cingulate cortex. What if you could get an anti-amyloid agent just to that area and target that? That's the goal of some of the work that we're doing right now. Next slide, please. And if you look at this slide, you'll see on the left with the colored map, the area that we're targeting with focus ultrasound. Right next to it is an MRI scan that shows no contrast. And then you see the contrast enhancement that overlaps with that target area right after they got focused ultrasound. And then 24 hours later, it's gone. So you could target that area, open up the blood-brain barrier, and then have it close back up within 24 hours. Next slide, please. And in the same patient, you could target back in the parietal lobe also and see if you could get drugs specifically to that area that you want to. Next slide. So what have we learned today? We can do this safely with our patients that are picked very, 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 very carefully. They have no bad outcomes. The barrier opens and closes. Sometimes it's a little more than 24 hours. We see no ill effects on their cognition or behavior. We certainly can't say it improves them. We think in some cases it may reduce the amount of amyloid in the target area, but I'm cautious about saying that in large areas until we get it really further worked out. So what are the next steps? The next steps are to see where else we can go with this. We have to think about this carefully. We have to be thoughtful and very safe. Next slide. So this might be a step in the right direction to be able to really target treatments to a specific area. But we have to make sure that we can do it safely for our patients and our families. And we have to see if we can do it quicker. I think 12 months is too long to get a drug in. If we could do it safely in a short amount of time, we save a lot of brain. And so with that, I'm going to pause and thank everybody for listening to what we had to present here. It's a privilege and an honor to be able to talk with you about these topics. I'm really devoted to this area. And if we can help you in any way, please let us know. I've given some information for how you can contact us about any research we do here, or if you need any clinical help, we're willing to help with that also. And with that, I'm going to stop and thank you again and introduce Dr. Giordani from the University of Michigan.
Everyone, thank you very much. That was a great talk to follow. What I'm going to talk to you today is a little bit about what's happened to research in the time of COVID and how some of the changes we've actually done we may keep to, because we've really found that by forcing ourselves to adapt, we've got some interesting approaches. Next slide. So I welcome you from the Michigan Alzheimer's Disease Center. Our center spans across 4 universities, sort of in a belt across Michigan, University of Michigan, Michigan State, and Wayne State. Next slide. So we all know research is not the same in the land of COVID, especially in some areas of the country. We've really been challenged in a number of ways that I'll sort of touch on tonight. They include recruitment of participants, getting out there to try to explain what we're doing and talk to people, how we do our evaluations for research, how we do our clinical evaluations, how we do our cognitive testing and so forth. And then also a little bit about how we've been looking at our center a number of different non-pharmacological and pharmacological, either drugs or no drugs interventions. And that's really changed as well. So I'm going to use one study as an example of that we're doing. Next slide. So let's talk a little bit about recruitment. Next slide. Just to give you an example of the problems we had during COVID, if we took 2019 to 2020 up to March of 2020, we'd already had 142 presentations by our faculty, multiple community events, reaching around 8,000 people, both in underserved communities as well as across other communities in Michigan and Northern Ohio. But from March 2020 to June of 2020, everything kind of went silent. We had a few faculty presentations on Zoom, and 19 of our community in-person events were just canceled. So that caused a big turnaround at our center. And now, for example, from about June of 2020 on, all of our faculty presentations are on Zoom. It's needed a lot of training for folks on how to use Zoom effectively if they're the only ones giving the talk and so forth. But we've had 18 speaker series. We've had 10 invited presentations for folks within our area. We've even had our annual participant appreciation event was on Zoom, and actually we got a very large number of people who attended to that. We've also already done 4 Alzheimer's Association research updates, 4 talks through Zoom. So most of our presenters, we've all become sort of experts in how to Zoom, which is a good thing, I hope. But many things we've noticed about this, for example, is, and even in the last Alzheimer's Disease International Conference, it became very clear, if you have an option through the internet, you just reach so many more people. I mean, I think the Alzheimer's AAIC meeting, the big Alzheimer's International meeting usually brings in around 5,500 people and brought in over double that over Zoom this past year. So there's a lot to think about these ways of reaching both fellow scientists as well as people in the community. Next slide. So I'll mention another thing we've really found as a blossoming way to reach people, and we're reaching many more people. So if you see this coming through, this is part of the reason why we've learned that social media recruiting, Facebook and other things, and sort of targeting different ads for different ages of individuals or whatever works can be very effective. So our university even has a group that actually sets up and launches these campaigns for us, sets up where to go, but it's still not easy. So in the first week of one of the campaigns for one of our studies, our ad was seen by around 2,600 people. Only 170 of those really clicked the tell me more about the study, and only 10 of them really felt that they belonged in this study and completed our questionnaire. But still, it is a way for us to begin. Each time we do this, we see more and more individuals. So, look for Michigan in a social media campaign in your Facebook page, maybe in the future. Next one, please. So let's talk about clinical evaluations. Next slide. So anybody who's participated in research remembers what it looks like at the bottom of the page. One person sits on one side of the table and passes on materials, puzzles, papers, whatever, for the other person to fill out. That's how we've done memory testing. That's how we've done all of our cognitive clinical evaluations as people who come into our Alzheimer's Center, as well as all 33 Alzheimer's centers around the country. We're all collecting exactly the same data that way until COVID. So that forced some major changes. For example, first thing that happened was the Alzheimer's centers all got together and started a telephone evaluation program where many of the same questions and other things were done on the phone. When people have computers available, it gives you a little more options to do. And so we're doing testing via computers now, so that we can reach people in their own homes with their own computers, just as we can with the telephone, but now we get a little more information. Now at our center, as well as a number of other centers now, Alzheimer's centers, there's a lot of interest in doing assessments with home-based tablets, with cell phones as well, that these become new options and ways to research, which really had sort of maybe been a little bit in the periphery before, but now are in the forefront of some of the research going on. And I'll also talk a little bit today briefly about feedback, because what we've found is that everybody wants feedback about their results up to what the study allows. Some studies allow more feedback than others about test results and other things. And feedback for us, we realize, is a major issue. Don't come into our community and do all this research and not give us something back. Tell me how I'm doing. So we'll talk about some of our feedback work as well. Next slide. So let's look at some clinical evaluations. This is things that have changed in the research of Dr. Kelly Ryan and things that have changed in the research of Dr. Wojciech. Next slide. So up on the top left is the normal way that Dr. Ryan's research participants used to be tested and tests used to be presented. So then if you look at the bottom slide, there's sort of an ocean between those two people. That's what testing became. Or in the back slide, in the next slide, excuse me, up there, you can see one participant sitting way in front and the examiner sits in the back, and the examiner actually uses a laser beam from one of those old-fashioned laser pointers to show the person what to do. This is a little clunky at best, but it's sort of all the different methodology we've been trying. So Dr. Ryan got a little frustrated and went back to work she'd done very early on with her own digital battery, which she and a group put together, that apply very similar cognitive measures. There are multiples of these batteries out there now, but to testing for individuals so that somebody can be tested at different times of the day, all by what they feel like and when they feel like doing it. Next slide. Now, Dr. Wojciech up in the upper right, we've been doing a lot of research in the community in Detroit in what are the best ways in which we can most easily identify people with the earliest changes in cognition. So one of the ways we've been doing quite a bit of work with is EEG. So we can even come to your office and do a portable EEG system. Now, this individual is using one of our sort of large arrays, but we have even smaller arrays like a baseball cap that basically we can do this testing and we can match it with computerized cognitive testing. We can do this testing wherever people are. The difficulty with COVID was you couldn't do that. And so you had to turn to the telephone. And we've been really gaining important information too, again, realizing the amount of information we can gain on the telephone, both cognitive testing to ahead of time, see if somebody is really appropriate for the research study, to gain information about their quality of living and other things they do. And really, this is something that we used to not do, insisting on everybody coming in, but we can now do it over the telephone. Next slide. And in his work, Dr. Wojciech and I have put together a number of studies looking at now older African Americans' experience about COVID-19 during the pandemic, as well as during the recovery period. And one of the things we found is that 25% of older African Americans clearly experience moderate to severe anxiety, but that some of the predictors of this anxiety fit along things we might expect. The amount of media coverage, concerns about what will it be like when I can move around freely again, concerns about, can I really get adequate protective equipment, or can I get those supplies I need? All of these concerns were driving very significant anxiety in some individuals living at home, either alone or in a family. And then also the impact of the disease. So in the first 100 people we talked to, only one reported a COVID-19 infection early on. And this was before our current run through, but these older African Americans were most affected by, half of them had an illness in the family, 31% had a death in the family, and this is in downtown Detroit, and 69% reported significant feelings of isolation. So all of these issues and a lot of concern about how COVID had been developed, but all of these issues, we could now easily reach 100 people much faster than we could before. Next slide, please. I'll also talk a little bit about some of the work we've done in looking at complex, what we call IADLs, or adaptive daily living tasks, interactive tasks that we have to do, sort of higher level tasks. So for example, one is driving. If you think about driving, it's one of the best cognitive tests you can have. You have to safely get from this point or to another driving your car. So we've been really interested in that. If you go over here in the next slide, we really talk about, we used to do this in a room with 3 small computers. Now we do it with a big system that moves and bounces along with the person, but still the person is there. And so because of this, we've moved completely to a car, pretty much. And so people wear a watch that tells us heart rate, respiration, all sorts of other physiological changes. In the bottom of their back seat is a little box with all sorts of radar and sonar, and now we can track people for months at a time. Next slide. I'm sorry, this is one I couldn't resist, those vexing little problems when you're trying to test from home. In no way do I condone this, but sometimes I have to hide upstairs here while my 6-year-old grandson is running around downstairs. Next slide, please. Let's talk about intervention research real quickly. So I'm going to mention some research done by Dr. Ben Hampstead that's really very interesting. Next slide. Next, yeah. Dr. Hampstead is looking at something called TDCS, which is a brain stimulation, which you can do both with paddles on the top left of the screen or electrodes on the bottom right that apply a very small current, about a 9-volt current. But what we found through research is this seems to really allow neurons, those cells up in the brain, to communicate a little more effectively. Next slide. So for example, we can even look at what happens when we do in the upper part, what happens when we use TDCS, both sham or real, and actually look at changes in functional imaging studies. It's really interesting. We can target GABA in the brain and see what happens to that important chemical. And we also know that on the bottom left, it looks like the areas not affected by Alzheimer's disease don't show so much change with stimulation, but cognitive regions affected by Alzheimer's disease do appear to normalize or have greater stimulation while they're doing this. And we do this now with cognitive training as well. Next slide. So one of the problems is you can't bring people in to do this anymore. It just doesn't work. So one of the things Dr. Hampstead has pioneered is the ability to use an MRI scan of the person, create a brain map, and actually use a little textured hat of electrodes that somebody can just take home. And now we have folks delivering stimulation all across the state. Now, next slide. I'll talk very briefly also about feedback, because this is very important to me in the center. And there's a lot of words on these slides, but don't worry about that. I just want to go through them quickly. Next slide. So we've got a lot of challenges that people have. Both participants want more feedback, but we're never quite sure if they understand it. And then our staffing has problems sort of getting there, giving the feedback and so forth. Next slide. So we've changed our feedback process, basically heavily relying on the phone and computer, because people just can't come back in often for that next session. Next slide. So we have lots of different slides we use for everybody. Feedback slides that come in that we explain about where they are in their cognitive testing. Next slide. And these are handouts that can go home. Lots of different handouts about what are the next steps based on our research testing. Should you look here? Should you look there? Next slide. And we also have handouts that we send out then about blood test results, what those mean and how that fits you in particular. Next slide. As well as we have feedback brochures that go summarize the feedback that that individual got over the phone or over a video. Next slide. So all of this stuff goes together along with, most importantly, all sorts of information that can go out about wellness services, hospice care, mental health resources. We've got different cards that go out for just about every concern an older individual may have in our area. Next slide. So lessons learned real quickly. Remote work seems to work effectively. Social media works. Zooming can be taught even to people like me. Our staff needs some training, but it works. We tried to figure out how to get a big MRI machine into a telephone and it didn't work, but we've got a lot of things going on. And that's it. Thank you very much. Jennifer's back there saying I probably went about 2 minutes over and she's angry, but.
Thank you,
regarding
Dr.
getting-
Jayarada. I'm Jagat Pillai. I'm a neurologist at the Center for Brain Health at the Cleveland Clinic and also part of the Cleveland Alzheimer's Disease Research Center. I'm a behavioral neurologist, so I see patients with Alzheimer's disease, among other conditions that causes changes in their thinking or cognition, and try to find help for them and their families. I really appreciate this time with you because what I really like to talk about today is, and after I spend a lot of time with my patients, there are a lot of other topics that often gets missed. You know, what is the big picture in terms of where are we with treatments and what does the future look like? And what can each of us do to help, find new cures for this disease? So that really was the driver for this conversation that I wanted to have today. Next slide, please. So over the next few minutes, I'm going to give a brief overview of what I consider as first generation and second generation therapies in Alzheimer's disease. Give you an idea of what the new insights that we have formed regarding clinical and pathological changes in Alzheimer's disease and how we think about the disease now, clinically. And also look a little ahead into the future and think about, what is a new generation of therapies in Alzheimer's disease? How does it, how is it going to look like? Next slide, please. So this is an overview of what the first and second generation therapies that are currently available in the clinic look like. The first generation therapies are things like lifestyle modifications, decreasing your risk for developing Alzheimer's disease or decreasing the severity of symptoms. A cognitive occupational speech therapy to compensate for some of the cognitive deficits, or medications like donepezil, rivastigmine, galantamine, memantine. And second generation therapies are things like aducanumab. These are amyloid removing therapies. And I'm going to talk about these things in a little bit detail next. Next slide, please. So what is the goal of first generation therapies? It's important to know they primarily aim at boosting mechanisms that can help compensate for ongoing cognitive declines. They don't stop the disease progression, but help boost, your cognitive abilities in spite of the disease changes. So the target population for these therapies are clinically symptomatic Alzheimer's dementia. So these therapies are being our mainstay for the last 2 decades or even more for some of them, about 3 to 4 decades. And primarily the workhorse is the acetylcholinesterase inhibitors like donepezil, rivastigmine, galantamine that boost a neurochemical in the brain, acetylcholine, that's important for alertness and help you handle your daily tasks better if you are symptomatic with Alzheimer's disease dementia. The other medications are memantine, which is an NMDA receptor antagonist, which kind of babysits the neurons or the cells in the brain so they don't die off fast enough, so the person is more engaged in their daily routine. Vascular risk factors like hypertension, diabetes, high cholesterol, managing those along with dietary management also can help mitigate the severity of the dementia. Compensatory abilities like speech therapy, occupational therapy, and cognitive therapy help people strategize and work around some of the deficits that are forming in them. And we use medications to manage some of the behavioral changes that often comes along with Alzheimer's disease. So as a group, these are considered the first generation therapies, and your physician should be familiar with all of them and make them aware of what's appropriate in the right clinical context. Next slide, please. But they do have some limitation. The main limitation is they do not stop the disease progression. And the second is that they have an assumption that Alzheimer's disease dementia is the same across each individual. So there's no individualized management here. Next slide, please. So we have now the new second generation therapies. And here the goal is to modify the disease, to prevent or slow the disease progression by targeting the removal of the amyloid protein plaques that Rebecca was talking about and the tau protein accumulation. Here, the target population is earlier stages of Alzheimer's disease when, not really at the state of dementia, but maybe a little earlier in the disease stage itself. And here, the primary workhorse that has been, just approved last year was aducanumab, which is an anti-amyloid therapy that removes the amyloid plaques. And it has been FDA approved, and it's being offered in some centers, though not in every center as of now. There are also many other clinical trials available and ongoing for anti-amyloid therapies that you can access if you have a diagnosis of Alzheimer's disease and you take part in those clinical trials. There are also anti-tau therapies that remove the tau protein in the brain that's causing cognitive impairment. So those are also available as clinical trials. Next slide, please. So what are the limitations of the second generation therapies? It's still early days for these therapies, so it's still not clear if it, actually stops the continued disease progression, or again, it kind of mitigates the progression. So that's still an open question. There are also assumptions that the disease progression is always related to amyloid and tau, but removing amyloid and tau will slow or stop the disease. And that's an assumption or a hypothesis that these medications are working on. And it also assumes that if you have amyloid and you have Alzheimer's disease, it's kind of the same across all individuals. Next slide, please. So the key to all these first and second generation therapies is that what Alzheimer's disease means has also shifted for over years. Alzheimer's disease was first, described in 1901 by Dr. Alzheimer's, and we have had over a century. And what constitutes Alzheimer's disease has changed. So our thinking and the therapies and ways of mitigating that also has evolved over this time. Next slide, please. So currently in 2022, how a clinician thinks about Alzheimer's disease is that there's an underlying brain change of Alzheimer's disease, and that's called the neuropathology of Alzheimer's disease. And oftentimes, along with that neuropathology of Alzheimer's disease, that is amyloid plaques or tangles or tau tangles, there's often a co-pathology or coexisting problem, maybe from a vascular disease or a Lewy body disease or things like that, that contribute to the pathology. Because of the pathology, you have a clinical symptom, and this can be diagnosed currently by using biomarkers. So these could be measures using a brain scan or something that you're measuring from your spinal fluid that can give you an understanding of what exactly is going on in your brain with high confidence. A new generation of blood biomarkers are also coming up, but they're not readily available in the clinic as of now. So the workhorses are just brain imaging and spinal fluid testing for now. And once you have those things, we can actually stage the disease. The preclinical stage of Alzheimer's disease is a person when someone is still completely normally functioning, but you can still have these changes going on in the background. Whereas MCI or mild cognitive impairment is a stage when somebody is started to have changes in their thinking, but they can compensate and kind of live independently. Whereas at the point of dementia, a person is no longer able to compensate for the cognitive problems they're having, and they need help to take care of themselves. And we also can think about this as typical AD, where somebody has memory problems that begins with memory problems. Whereas atypical AD often means that they have some other problem. Maybe it's a difficulty speaking that's the issue with that's the earliest presentation, or maybe they have difficulty seeing things clearly. That could be also a sign of Alzheimer's disease. And we use the word mixed dementia when people have more than one reason that's causing the Alzheimer's disease-like symptoms. Next slide, please. And these are some of the subtypes of Alzheimer's disease. We always think about Alzheimer's disease as people having memory issues, but now we recognize, if the part of the brain that's involved, the front of the brain is more involved, you can have more judgment problems or executive function changes. Or if it's affecting the side of the brain that's important for language, the presenting problem, the changes that you're noticing are going to be related to, expressing yourself, language-related issues. Whereas if it's affecting more in the back of the brain where visual information is being processed, you're going to have a lot more visual spatial problems. So these are considered some clinical subtypes of the disease. Next slide, please. So because of these clinical subtypes, there are also pathological subtypes, what's underlying all those things. So even if you get a scan or a biomarker that shows you have amyloid positive, that means you have amyloid plaques in your brain, it can be purely from Alzheimer's disease, or it could be a combination of Alzheimer's and vascular changes, or Alzheimer's and Lewy body changes, or Alzheimer's and TDP-43 changes, or maybe you have Alzheimer's disease with a very highly pro-inflammatory state in the brain. So all of these possibilities exist, and that can have slightly different clinical presentations, even though the underlying diagnosis will be something like Alzheimer's disease, the positive biomarker for Alzheimer's disease changes. Next slide, please. So each therapy that we are looking into the future, what we call as third generation therapies, actually not only target just the amyloid changes, but also trying to target things like neuroinflammation or the changes going on related to inflammatory response in the brain related to all the amyloid, or maybe it's related to vascular or blood-brain barrier changes that Dr. Howard was talking about. Or we can have Lewy body aggregation that is also being targeted along with amyloid, or another protein called TDP-43. And we can also have more targeted therapies, maybe managing their language changes using TMS that's being trialed, just like Dr. Giordano was talking about, or using other therapies managing their visual spatial deficits and things like that. Next slide, please. So when we think of future third generation therapies, I want you to look at this slide. The bottom axis is time, and the red line shows that a person starts on normal aging, goes to preclinical AD, then starts MCI, then AD dementia over a period of time. And as the curve comes down, their cognitive function is coming down. The current medications are at the bottom. They're mostly targeting people at the AD stage of symptoms. And the future medications, we're also targeting earlier stages of the disease, starting from preclinical AD and a lot more mild cognitive impairment stages of the disease. Next slide, please. So the goal for future generation therapy is tailored therapies to individuals across each of the subtypes of the Alzheimer's disease, whether it's a clinical subtype or a pathological subtype, and to stop the disease at the earliest stages. And the target population would be someone with Alzheimer's disease biomarkers, in additional pathology. If they have a co-pathology, how do you target that? And also clinical subtyping to make sure that the therapy is appropriate for their clinical symptoms. Next slide, please. So what are the limitations here? These are still at very early stages of clinical implementation and relevance. So many of them are in the planning or early clinical trial stages. And there are a lot of research going on in this area, and we can see a lot of progress in the next 5 years in these regions. The assumption here is that Alzheimer's disease state differs across individuals. Even if you have Alzheimer's disease biomarkers, it tells you that you need a lot more to specifically understand each person's unique context. And then we should focus on targeting the key pathology that drives the disease progression. Next slide, please. So where are we going? So with the third generation therapeutics, we will hope to provide tailored therapies, as I mentioned, stop the disease at the earliest stages, before onset of symptoms probably, and prevent disease onset for those at risk for future development of Alzheimer's disease. Is that we may be family members with Alzheimer's disease, Alzheimer's disease in their history. That could be something that a lot of trials are starting up there. And there is also likely to be multi-domain interventions to prevent cognitive decline. So risk factor mitigation, that's managing things like vascular risk factors, like blood pressure, cholesterol, diabetes, insulin resistance, improving cognitive reserve, making sure that you're having a cognitively stimulating life, and something that helps improve your reserve capacity to compensate for some of the changes that comes on with Alzheimer's disease. Early biomarker to identify what kind of specific pathology is underlying the changes, and maybe a combination of the first, second, and third generation therapies based on each individual patient. Next slide, please. So I think for all of these things, there are a lot of trials, and there are 126 agents at over 152 trials, that Rebecca was mentioning, and over 28 treatments in phase 3 trials. That means these are trials that have gone through phase 1 and phase 2. They've shown some exciting promise, and they need to show that in large numbers of people. So there are a lot of opportunities, and more than 38,000 participants are required for current registered clinical trials. But it's always a challenge to have patients appropriately matched to each trial. So all of our efforts are really needed to push these efforts forward and find new solutions to make the third generation therapies so that we can have people not developing Alzheimer's in the future. Next slide, please. So all this work I do is supported by the Cleveland Alzheimer's Disease Research Center that's based out of Cleveland. That's a combination of institutions in the Cleveland area, including the Cleveland Clinic, the Case Western Reserve University, the VA hospital here, and I had the really a great opportunity to work with a team of colleagues who are expert neurologists, geriatrists, and neuropsychologists, and we do a lot of clinical trial translation research, and I'm happy to talk about that more. And thank you for your attention.
Thank you so much to all the speakers. I really want to thank you for everything that you have shared tonight. And we have a number of questions. The presenters have done an amazing job keeping up with questions and Q&A, but I'm still going to bring up a couple of those because I know there's something that other people would like to hear. And really, thank you, speakers, for keeping as close to time as possible. I know it's very hard when you start talking about your work. So I'm going to start with a question to Rebecca. Is there a correlation to cognitive improvement when there is a reduction in the amyloid in the brain or the p-tau217 in the blood?
So what we've seen in clinical trials to date is mostly from phase 2 and phase 3 clinical studies that, yes, removing amyloid does seem to have some ability to change the cognitive trajectory. Now, the newest drug, Aduhelm, that was approved by the FDA recently, had two, unfortunately, conflicting trial results in phase 3. One did show significant impact on cognition, and the other did not. So that's why they'll be performing a confirmatory study. But some of the newer drugs that are kind of completing their phase 2 and phase 3 studies in the anti-amyloid class have shown that when some correlations, but then it needs to be confirmed in larger phase 3 studies at this point, that removing amyloid or preventing amyloid buildup does seem to have a link to a change in cognitive decline. So I think it's really hard, I think, with these studies because most of these individuals are being invited into the clinical trials at the earliest phases of disease, as we were talking about mild cognitive impairment due to Alzheimer's or mild Alzheimer's dementia, where those cognitive changes can be quite small. on cognitive testing. So that's where the research is looking to make sure that we test people long enough over time to be able to detect those very small changes, with the hope that eventually we'll have a better understanding on if it's actually slowing disease progression or not. But what we're seeing based off of the biomarker data and some of the cognitive testing in clinical trials is suggesting that yes, there is a potential change in trajectory.
Thank you. Dr. Hout, I know this is a question that you started to address in chat, but I thought other people would like to hear about it. Is treatment aimed at fixing an asymptomatic brain or reversing the deterioration that's already happened once it's been diagnosed? And if it is about fixing a brain without symptoms, then how do you know you need that treatment?
So I think at this time, we're really not at a place where we can fix brains or the damage that may have been done and the symptoms that are there. I think what we're really trying to do is to prevent decline or prevent further decline, to stabilize the situation. One of the current thoughts in the field is, because we've had such a hard time and nobody's come up with a cure or a silver bullet for this, is to see what we can do adding a number of treatments together that may delay the onset or delay the progression so that people may age out of the process. And so if you add in donepezil and lifestyle changes and Aduhelm and maybe another intervention, you may delay the onset for people by 5 to 10 years. And if your onset was going to be at age 80, chances of you developing the disease then go down. Our goal is to prevent or slow at this point, not reverse.
Thank you. Anybody have anything else they want to add to that question before we move on? Okay, great. Dr. Pillai, this really pertains to your presentation. This came up while you were talking, but why, a lot of people are frustrated that it's hard to get a diagnosis. So one of the questions is, why is it so hard to get a diagnosis? And do GPs really understand the disease and the treatments available? And this came up especially when you were talking about cognitive and occupational and speech therapy, that a number of people, someone said, my relative's been diagnosed and I've never heard about any of those treatments. So I know that's kind of a big question, but I'm hoping you can weigh in.
Yeah, absolutely. It is a big question, but it's not an uncommon question I have faced. So I have put some thought into this, and my brief answer is that I think the GPs are in a very tough spot because the field has changed and is growing pretty rapidly. I mean, even for a specialist in different areas, I mean, it's tough to keep up with all the new changes and diagnostic tools that have become available. And so first aspect of the challenge is the diagnosis. How we make a diagnosis has changed significantly in the last 5 years. But unfortunately, the tools that are needed for making accurate diagnosis are not readily available unless you're in a tertiary medical center or in a specialist practice. And organizations like the Alzheimer's Association have done a great job in improving access to these things using studies like the IDS trial that Rebecca was mentioning. So I suspect this is going to get better, especially since once we start getting blood-based biomarkers available for diagnosis. The second question is in terms of, what kind of treatment options that we can do. And that is also changing. I think the big issue is a mental block in the sense that when people do get diagnosed with Alzheimer's disease, oftentimes I hear some of my patients say to me that their experience was there's nothing to be done at this point. And this is really heartbreaking for families and patients to hear. And there has to be a shift in approach there. And I think more education to provide the general practitioners options to know what in different ways they can actually provide and improve the life of patients with Alzheimer's disease is going to be very crucial. So all is not lost. There are a lot of things we can do. I think the best thing I have done as a physician is tell them that, yeah, there are a lot of things you can do that's going to help improve the quality of life and have a very meaningful life and choices that you can make going forward. And that has really made a huge difference for some of my patients.
Rebecca, I'm going to give you our last question. We have so many good questions. I do want to say before we do that, We are going to follow up, especially for those people that ask questions specifically around services that we can provide. We'll be following up directly with you. But Rebecca, one of the questions that came up is, and I think this also kind of ties into the recent issues with the FDA and CMS, but should the association be doing more on a political front, or is it really a science front? And, kind of where do we need to be making a push to make sure that everyone understands the progress that's being made, but the progress that needs to continue to be made?
So our goal as an organization is that we are trying to address Alzheimer's disease in a multifactorial way. And that is not only through research, but we also are doing this to make sure that there's enough research funding and enough care infrastructure and enough training and so much that is absolutely needed to provide the best health outcomes for individuals that are living with Alzheimer's and other dementia. So we continue to advocate for increased federal funding at the level of the NIH to make sure that there are billions of dollars every year going to researchers around the country to push us into new innovative strategies for treatment and detection and care. We're up to $3.4 billion, which is just amazing to see. When we look back at 2011, I think there was only somewhere just over 300 or $448 million. And a lot of that has to do with how we continue to advocate for progress through NAPA, which is the National Alzheimer's Project Act. We recently had in 2018, the Bold Infrastructure for Alzheimer's Act, which really helps to expand a priority of making sure that we can create centers of excellence that are designed to give public health agencies the tools and resources necessary to act in the community. And then I think more recently, just to give you all a heads up, we were able to enable the ENACT Act, which is Equity in Neuroscience and Alzheimer's Clinical Trials. And this really allows us to expand access and increase outreach to underrepresented populations and to increase diversity among clinical trial staff and to reduce the participation burden for individuals in clinical trials for Alzheimer's and other dementias. So those are just a few ways that the association continues to advocate on that sort of level, but all of it still falls back to the science and research needed to support many of these initiatives.
Thank you so much. Again, I want to thank all the presenters. We're getting lots of compliments and Q&A on the presentation. Again, we'll be following up with you. I know on the last slide, we have some contact information, and we'll also send you a copy of the presentation, so you'll be able to see that. But again, thank you so much, and look forward to hearing from us if you have a question we need to follow up on. And I hope everyone has a great evening. Thank you.